To week 3. Today's topic is going to be a big introduction on obesity. No pun on the word there, big. Anyway, so this is, I've done a presentation, which is why the date is on here is November 2019, and we're sitting here in January of 2021. But I didn't edit all of that out just to kind of let you know that I did do a presentation, shared this with the with ACSM's affiliate organization called CEPA. I would urge you to hop on the website if this is new to you, but CEPA is a great organization for those of you that are looking to move into a clinical direction with your degree. As a master's degree student, many are looking to work with high-risk patients. But anyways, so I'm going to talk about the role of an exercise physiologist in the scope of bariatrics or obesity. And depending on what knowledge you bring about obesity to this class will kind of vary how much you get out of some of this stuff. So when you think about, so again, CEPA is an organization that is within ACSM, and it's a sub-affiliate society. Slide my head over there. Here we go. Okay. So the definition of a clinical exercise physiologist involves the application of exercise science, exercise physiology, to prevent and delay the onset of chronic disease in healthy participants. Clinical exercise phys provides therapeutic or functional benefits to patients with underlying clinical pathologies. So many of you that are more in strength and conditioning, fitness, personal training, you're dealing with healthy populations, right? Which is great, right? They're great, they're fun, they could do a lot. Someone who's working with clients that have underlying pathologies, they have high risk, they have a lot of risk factors, that's when we use the word clinical exercise physiologist. So CEPs are healthcare professionals. We're classified as an allied healthcare professional using fundamental principles of exercise physiology in a clinical setting to minimize the risk for chronic diseases. So we're trying to minimize more problems from happening. That it's associated primarily with being sedentary, so physical inactivity, and treating those that are already afflicted with chronic diseases. Around 6,000 practicing CEPs right now in the nation, and they believe that number, the prediction of that number should go higher with our aging population. So the scope of practice is they're responsible for exercise testing, evaluation, and supervision. Some of these things you may have already learned in other classes, others this is new to you, but being able to get baseline assessment, know how to evaluate, know how to supervise, know how to work with people that are high risk. You commonly find CEPs in cardiac, vascular, pulmonary rehab, cancer rehab centers, in obesity clinics, diabetes, stress testing, universities, university fitness centers, university labs, research facilities, some for the government. A lot actually happen to work for the VA system, the VA hospital, Veterans Hospital, corporate wellness, so big, nice, wealthy corporations, and then commercial health and fitness settings. So really a wide variety from medical fitness centers to government employees to, a place like Goodyear, would hire somebody. What do you need to be a CEP? Well, CEP is anatomy, so kind of what you're getting in a decent graduate program would be anatomy, physiology. Physiology is organ systems physiology, basic chemistry, biology, psychology, pharmacology. Understand the normal physiological response to acute and chronic exercise before attempting to manage it and when you're dealing with someone who you need to rehab. So a CEP should have an undergraduate degree or a graduate degree in a related major that's going to cover all of these things. Should have done a clinical internship. So many of you that are thinking about what you want to do for your internships, this might be a great opportunity to do a clinical opportunity. Even if it's not required by the school, which Dr. O doesn't have a specific of what he requires. It's more what you want your resume to look like. So do you want to try to get into the Cleveland Clinic, or you want to go down to Columbus? I mean, you don't have to do your internship here in Akron. So if you've got ties to other cities and other hospitals, use them. Over the years, I've had students go to the Arizona Heart Institute. I've had students do stuff for the NFL. I mean, it doesn't, just because I'm teaching you in this class, it doesn't need to be clinical, but it doesn't need to be in the city either, right? It's kind of great to go spend a summer or a semester elsewhere to really build your resume. But for CEPs, we're looking for it to be clinical, and you need to pass an accreditation exam. Okay, so clinical CEPA, the organization that I'm talking a lot about, has been around since 2008. It's really working hard to advance the profession towards licensure. It's trying to get universities to become accredited. So we are not an accredited university. There are some that are accredited. That means that the curriculum you're learning will align with the exam you've got to pass. So it's kind of where we're trying to push this towards. There's a fabulous journal of clinical exercise physiology. Hop on the website, the CEPA website, and I'll share some information as we go through this semester about it as well. So when we think about obesity, we once, way back in time historically, an obese image, right? If you think about some of the Renaissance paintings and some of the, kind of our trip to Europe, we've seen some of these fabulous sculptures, and they're big and voluptuous, and that once was what people prayed to, because the sign of being fat was a sign of wealth, right? That gluttony that happened among the kings, and those old photos art history sat through. Then time changed, and now the inverse happens, where now this gluttony is everywhere, obesity is everywhere, and now there's these fake bodies that people are, looking up to. So when you think about what is obesity, obesity is excessive fat accumulation. So all of the adipose cells that end up collecting, the presence and severity of obesity can be measured by DEXA, it can be measured by BOD-POD, right? You're looking at what is your BMI, fat distribution, right? Apple versus the pear, so the belly versus the hips, doing different risk scores, looking at comorbidities, right? Risk factors. These should not define obesity, but these are all the things we're measuring to look at the risk factors. How much fat is excessive is not very well defined, and it varies with age, it varies with males, females, it varies with genetic background, and other biological markers. So we don't really have a pinpoint. It's not like blood pressure that we have at like 120/80, no budging. Obesity is a little bit more gray area. So it has been defined. So this is the medical association definition is chronic relapsing, multifactorial, neurobehavioral disease wherein increased body fat promotes adipose tissue dysfunction, abnormal fat mass, physical forces resulting in adverse metabolic, right? So metabolic problems, biomechanical, and psychosocial health consequences, which is a mouthful of a definition. I mean, it encompasses so much. It is now considered a disease. It is associated with impaired bodily functions. Like other diseases, it results from physiological dysfunctions by all of these other forces within our society is really the trigger. It really is, fat cells are linked to over 150 comorbid diseases. Right? There's this link of how unhealthy fat cells are. It's associated with substantial burden of morbidity, as well as dying early, right? Premature death. So in 2013, the American Medical Association, the AMA, which is the largest physician organization, right? In their annual meeting, not very long ago, 2013, they finally all agreed that obesity is now recognized as a disease and not a condition. It's a disease now, right? Recognizing it as a disease that requires medical interventions to advance obesity treatment and prevention. So historical view was kind of people made bad lifestyle, they had the poor willpower, psychological mindset wasn't there. The old was blame, right? Pointing fingers. The current perspective is that it's dysfunction, that is complex, physiological regulatory system, devastating effects on efficacy and quality of life. I have this circle of stuff, right? So it's multifactorial. So epigenetics, genetics and epigenetics. Environmental, right? Stuff that we, in our society. Environmental, not just the air, but things we're doing. The immune response, the endocrine, medical, and neurobehavioral. The word adiposopathy, this is a abnormal endocrine immune response. So when you think about adipose cell and a dysfunction adipose cell, what happens is in the immune system is what we call SFD, sick fat disease. Sick fat disease is the other word for adipopathy. My tongue. So what you see when you have too much fat is you have blood pressure that goes up, blood glucose levels go up, dyslipidemia, cholesterol goes up, and we call this metabolic disease, right? Normal pathological physical forces with what we call fat mass disease. With fat mass disease, we see more biomechanical structural things happen. So knees and back, right? Stress on the weight-bearing joints, immobility, people aren't able to walk up and down the steps, tissue compression, that is what leads to sleep apnea, right? So all this excess fat is sleep apnea, gastrointestinal reflux, high blood pressure, and tissue friction, right? Which causes all of these things with skin and tissue stuff. So fat cells are not good either way, whether we're looking at the sick fat cell or looking at this fat mass disease, right? It's this abnormal response that happens in our body, either inside kind of cellular to, right, when we're looking at glucose and blood pressure, or systemically to the body. So to manage this, right, an adult patient that's overweight or obesity, we have things we want to address. Health needs to be improved. Quality of life needs to be addressed. And then we also need to improve their body weight and body composition. So this is what we call the algorithm for obesity. So it is a disease up here at the top. Use my mouse. It's a disease. With data collection, evaluation, and assessment, we got to manage and all of these things are what's going on with the clinician, right? So collect all the data you have on the patient. Evaluate everything you can. What's going on wrong, what's working, what's not working, and what kind of decisions are we going to make to manage this? Motivational interviewing, some of you know what this is already, is now when we engage the patient to have a say in this treatment pathway. So some of these things we really want to address. Nutritional intervention. So this is where the registered dietitian comes into play, reading labels, meal planning, physical activity person like ourselves with physical activity counseling, behavioral therapy, right? Psychologist has a very, very key role in obesity. Pharmacotherapy, what are we looking at? What medicines are they on? Could the medicines be altering? Any triggers with metabolic system? We don't really have an easy pill for fat, but looking at all of pharmacological things that they're taking. And then the other one we want to look at is, are they a factor, are they a candidate for bariatric surgery? So bariatric surgery, right, stomach and intestines and doing this. So this is where, we fit in on this obesity with the physical activity person, but to be honest, when I'm working, I work hand in hand with the nutrition therapy and the behavioral therapy. In fact, many of the times, all three of us, I say that we're a triangle, we'll work together as a team, sometimes with the patient, with all of us together. So medical management, right, coordinating all of this is the trick. So this line is exactly what I had on that last slide. So this is what we call medical management coordination. And if someone's thinking, I want to have bariatric surgery, we want to make sure we've addressed all of the other things. We have everything well balanced to make a difference. Treatments. So the risk, cost versus the potency. So lifestyle of just nutrition, physical activity, yep, it's, low risk, low cost, decent response. Are we going to see lots of weight loss? Not always. And if they lose it, it's tough to maintain. This is for obese, morbid obese. Combining lifestyle with medication, getting the right concoction of medicines on board with all of these, we have a little bit more potency. Very low calorie diet we know is going to drop weight, but it's a little bit more higher risk, hard to stick with. Right? And that's kind of what a lot of times people will try, is just severe diet, low calorie. Surgery has the highest potency, and for some people they're resistant to accept this, but it's proven that bariatric surgery long term over everything else, in a combination with all of the behavioral things, really has the best potency. So We want to be aware of that when people are choosing. Who qualifies for bariatric surgery, right? Well, we're looking at body fat that's going to be in a BMI above 35, right? Severely or morbid obese is what category is going to put somebody at the category to have bariatric surgery. So 100 pounds above ideal body weight, BMI 40 or greater if they have no comorbidities. Comorbidities would be all those risk factors we've talked about. Maybe we haven't talked about it in this class. I get my classes all confused. But anyways, risk factors and comorbidities. Or if they have a lower BMI, they need to present with comorbidities. So diabetes, sleep apnea, there's a long list, right? Hypertension, age. Now, they are doing bariatric surgery on people under age 18. In fact, if you read the Beacon Journal just a couple of days ago, there was a big article on bariatric surgery at the Children's Hospital. They can do them at younger and they can do them at older. But ideally, most of the research is done on adult population. You're looking at someone who's already failed. So they want to have to share stories that I've been obese for X amount of years. I've tried, I've lost, I've regained, right? You're really wanting them to have tried options because for some people, diet and weight loss options will work. Health complications are definite. So they're kind of the more unhealthy they are to a limit, we know that they're going to be a good candidate because we're going to be able to get their diabetes in line and get their sleep apnea in line. However, they are going to have to go through an evaluation with a psychologist. And this is where the psychologist is looking for how healthy are they with no contraindications. So contraindication with bariatric surgery would be somebody who is an addict, alcoholic, right? That's going to eliminate their ability to have the surgery. And also looking for compliance. Can they stick to their appointments? Do they show up on time? Are they taking this seriously? Basic cognitive ability to understand the risk that when someone has bariatric surgery, they must follow the game plan, right? You start cheating, you're going to gain weight, and then they cannot redo the surgery, right? It's kind of a one and done surgery. So back in 1991, the National Institutes of Health came up with these indications, as I just read, either over 40 BMI or 35 with comorbidities, right? Diabetes is red because it's like the classic one. Hypertension, sleep apnea, blah, blah, blah. Failed attempts at dieting, patients should be seeking treatment. First time should be considered, this is the first time they're seeking help with their obesity, your first line of therapy is going to be diet, weight loss, lifestyle intervention, because it will work for some. If the 3-6+ months on a diet weight loss program is not working under physician supervision, then now they can look at being a candidate for bariatric surgery. This slide might be new to you. These are 3 different kind of symbols I have on here, right? So I've got the metabolic and bariatric surgery accreditation and quality improvement. If you're looking for a really nice bariatric clinic to learn about, to work in, to send your family member to, I would be looking for an accredited one by the American College of Surgeons. So ASMBS, you can hop on their websites and read about them, find hospitals that have surgeons that are accredited. The next one is called the American Board of Obesity Medicine. These are great. I work with some of these doctors. These are doctors that are what we call diplomats of obesity, where they are really well trained in diet and weight loss. Really well trained in diet and weight loss. So someone who's not ready for surgery might not be a candidate for surgery, going under one of these, a diplomat, and we have them here in town. Suma Health has some great diplomats of American Board of Obesity. And then this one is the board certified specialist. And this is an interesting one that I have not taken the exam myself. I do qualify to take it, but you have to have a bazillion hours of training. You commonly are a nurse. The common one is really a dietitian. So a dietitian, exercise physiologist, social worker, pharmacist, physical therapist, physician assistant, registered dietitian, clinical psychologist. Someone who's worked in obesity, has lots of experience, you pass this exam, and now you're recognized as a specialist. Again, you can look up who they are. And I share these with you just for information. I think it's important that you know in this field who are some of the people that are some of the gurus and who you want to have your own family member go to, or maybe you want to go volunteer, go and observe. When you think about types of surgery, this is where patients, if you get on Facebook at some of the bariatric surgery groups that are on there or some of the other social media groups, there's a lot of debate on what type of bariatric surgery somebody should have. And I always tell people it's really not our choice, it's the surgeon's choice, right? The doctor's going to take a look at the person's body, their history, their medical history, and decide whether they're going to do a restrictive procedure. And there's different ways we can call these: a Roux-en-Y, a sleeve. Those are our two common. These are all ways in which they do the surgery. It's all about the stomach and the intestines. And quite frankly, patients get caught up in the differences between the sleeve and the Roux-en-Y and all of these things. It's really up to the doctor and what he thinks your body is going to be best for. So they're all restrictive, and they're all going to be somewhat malabsorptive, only absorb so much. But the type of surgery, again, we're not doing the surgery, we're just helping the patient, but understanding there's different ways in which they do the procedure. So the two most common is what we call Roux-en-Y, right? The Roux-en-Y gastric bypass. The Roux-en-Y gastric bypass, is both restrictive and malabsorptive. So it's the way in which they cut the stomach and the intestines. So now it is only holding a very small, very, very small amount of food. They have to eat small portions, and it's got less of the intestines. So it's restrictive and malabsorptive. It's not going to go through all of the intestines to be able to uptake all of that food. The sleeve gastrectomy is similar but different, right? So the sleeve is where it is restrictive, not as malabsorptive. Again, it's a lot to understand, and quite frankly, patients get caught up on this, but I tell them, let the surgeon make the decision on what they think is best for you based on your nutrition and other prior health problems. What all of this does is a tool, right? So bariatric surgery is a tool. How effective the tool is going to be is up to the human that it belongs to. So humans need to change their behavior in order for the bariatric surgery to work. What we know, though, is they're going to drop weight quickly, improve metabolic health. So we are going to see teaching them how to exercise is what I call the insurance policy. So the surgeon gives them this new tool, right? This new digestive tool, right? So that's their tool. We, the exercise people, we're their insurance policy. We're going to teach them how to increase weight loss, get more weight off, and then once they're at their happy place, be able to maintain it. So how to do this is weight loss maintenance during caloric restriction. They're always in a caloric restricted state. We want to really help maintain muscle mass. This is a really big thing with weight loss, is how much muscle they lose. Really get muscle resistance training is super important. You all know it's important, but really, really important for these patients. Metabolic system is going to change. So when we talk about diabetes, everything begins changing because now we are losing all those bad fat cells that are so resistive to uptaking glucose. So increased hepatic insulin sensitivity. We now have beta cell function improving, insulin sensitivity improved, glucose effectiveness, cardiovascular fitness. All of these things change metabolic fitness. And then skeletal muscle, right? We want to really maintain muscle mass, skeletal function, increased capillary density, lipid oxidation, mitochondria content, all of these things. We want to get rid of the fat, right? So that's kind of the big thing. So physical activity is an important role. And, I think, Mike, you might be in this class, but Mike is training. He's got a great little, if you're doing a personal training business, a lot of people are fearful of working with fat people. Don't. Help them be an ally, help understand how to get people moving, that it hurts to move, right? Find how, when we're doing physical activity, the when, the what, the why, they have so many barriers. So what you and I are doing for exercise is not going to be the same as someone who's 300, 400 pounds. You can get them there if you are a good personal trainer and you really know how to coach them through this. So what are they currently doing? Frequency, intensity, time, enjoyment, time of day, tracking, logging on a notebook, tracking on an app. We want to be able to get access to facilities. Are they doing this in their home? What are all the barriers they perceive? Are they doing chair? Are they in a water? We've got so many layers of fitness training that's going that needs to be addressed in order for them to be successful. Biggest medical problems are going to be the heart, the lung, and the musculoskeletal, so knees, hips, back. Metabolic disease, acute coronary syndrome, ischemia, right? So they're ischemic, they're not getting blood flow as well as they should, so their intensity is going to be lower. Diabetes mellitus, a lot of hypoglycemia post-exercise, so beware that as they exercise, their blood sugar levels may drop, plummet fast. So we want to talk with them, make sure that you're keeping your sugars where they need to be. That's a whole other lecture on diabetes education, hypertension, and then watch their dyspnea, their shortness of breath. Contraindications need to be addressed. Contraindications need to be addressed for safe exercise. So before they have surgery, we want to get them up and moving. Even though they weigh a lot, they haven't really lost much weight. So I tell them pre-surgery, my goal is to decrease your time sitting, decrease sit time, increase steps. Bottom line, move. Then we're going to initiate a home walking program. They're walking in the hospital when they have surgery, same day they're out of the bed, right? Up and out of the bed, same day. Then they're, by about week 4, 5, 6, the surgeon, once everything is healed, which really usually by week 4, could be week 6, now they're advancing to the stage of get moving. Get moving for weight loss, get moving to be healthy. So it is the exercise, again, is that insurance policy that the surgery is going to work. And we want them to be able to maintain this. So we want to really, start them low and slow, and then slowly, gradually titrate up that program. So the guidelines right now are really not adequate because in order to lose weight, it needs to be a lot of minutes. We know that, right? So 150 minutes, 2 hours, 30 minutes moderate, 75 minutes if it's vigorous. So do you know the difference? Can you define moderate versus vigorous exercise? That's what I teach in an undergraduate class, right? So moderate to vigorous exercise is defined by MET level or how much of your oxygen uptake. So depending on how much they're doing really should indicate their minutes. In the very beginning, skip the minutes and focus on just getting them moving. So the first few weeks is just getting them used to walking. Walk the dog, get out of the chair, make them move. As they get moving, eventually we're going to start throwing these minutes on there. If you throw minutes on too soon, they're just going to quit and say, there's no way I can do 45 minutes of exercise. So start slow, chunk it down slow. With weight loss, again, we need to do a lot of minutes a week, right? This is minutes per week. 250 minutes or more. Strength training, significant restriction of food. That's kind of what we're looking for. So suboptimal weight loss. So with bariatric surgery, right, the majority of patients, I keep wanting to use my finger, 80% of our bariatric surgeries will be able to sustain their weight loss. Pretty impressive, isn't it? So people who opt for surgery, significant amount are going to be able to be awesome. Like lose the weight, keep it off, and then it talks about glucose. Be done. No longer even have diabetes, right? Throw it out the door. Everything is falling into place. 20% of them seem to be suboptimal. So who are these people? Smaller portion of patients that you see weight, they never really get to what they should. Insulin resistance, type 2 diabetes is still a problem. If we add exercise to this 20%, if we increase our energy expenditure, improve what's going on with the skeletal muscle system, improve sensitivity, we now can get these guys to lose weight. So when we talk about bariatric surgery, everyone needs to exercise, but we definitely have to recognize that there's going to be a good cohort of them that need way more hand-on-hand teaching them, educating them in order to really get where they need to be. What is the catalyst to do that, right? What is the catalyst for those suboptimal weight loss, right? It's getting them to move. If we move, right, if we can get them to move, it moves inside, right, the circulatory system, it's moving the glucose. Insulin resistance, right? So what's happening when they exercise is they are beginning to process things they weren't processing when they're just sedentary. So this insulin resistance is a problem, right? This is what they're at. They are insulin resistant. They're hungry all the time. They're tired. They have no energy. Their body's not uptaking the glucose like it's supposed to. Sugar is being stored as fat. Once we start using the exercise, we end up seeing better balance. So the steps for success with obesity is moving. right? Exercise, physical activity is vital for them. Begin with low intensity, bike, swim, walk, chair. Low fitness needs to just begin with intermittent chunks, 10 minutes, 15-minute chunks throughout the day. Slowly overload them. Make everybody aware of step count, right? Don't tell them 10,000 steps. No, 10,000 steps is too much. Start low, 4,000, 5,000, 3,000, right? Some people who are obese and not walking, give them a low for us, but a number that's realistic for them. So remember, surgery is the tool, exercise is that insurance policy that we want to be working on. So I already mentioned the triangle, right? Ourselves, exercise, diet, and psychologist, the three of us. And it also fits into this triangle of the three, I always call these priority areas. So every patient, when they wake up, they need to think, what am I doing physically today? Am I moving? Am I going to exercise? Yes, no. If I'm not exercising, how many minutes is my butt going to get out of that chair for? Eating, what am I eating? No longer skipping meals, no fast food, no binge eating. And then managing stress. And a lot of times that stress comes down to sleeping. If they're not sleeping adequately, are they seeing a psychologist? So those are what we want to, what are you eating? What are you doing? That's us, the doing people. And then the mental mindset. So what I'm going to have you wrap up with is watching this video. It's a documentary. The video is about 20 minutes long. I want you to take your time, and I want you to craft your own reflection based on this documentary. I want you to tell me how it made you feel. Were you sad, denial, who cares, I don't really care about it, whatever. There's a variety of feelings you're going to get when you watch this. You might just be really angry. You might just be like, I don't care. Elaborate on this, and you're going to share and upload. So all that information is on Brightspace for you.